This session is about evaluation and treatment of stress urinary incontinence. So I am going to set the stage here. First of all, these are my disclosures. I guess I didn't have a disclosure slide on the last one. I can't remember. So here are the AUA SUFU guidelines for the evaluation and treatment of stress incontinence. And it was these guidelines are from 2017. The thing that I really want to point out here is when we think about the evaluation of stress incontinence just in your general urology office, there are really 5 things that need to happen for the initial evaluation of the index patient with stress incontinence who comes in complaining of just simple stress incontinence. Of course, it's a history, we know that. It's a physical exam, but a physical exam that's focused predominantly in the pelvic area and the vaginal area, right? You need to demonstrate stress incontinence with a cough stress test, either in the dorsal thigh position or have them stand up. You need to do a post-void residual assessment to make sure that when they're voiding, they're emptying well. And the guidelines say you need to have a urinalysis. Of course, rule out anything that's going on in the bladder that could be like an infection or blood or something else that might tip you off. Is there something else going on that's causing her stress incontinence? So when you're working with residents or teaching or things like that, right, this is what we talk about, these things that they get tested on. There are really 5 things in the evaluation for stress incontinence. It's really easy to keep that in your mind. If this isn't something that you do a lot in your practice, but you want to try and at least start the evaluation, these are the things that the guidelines tell us are mandatory. The other things like doing cystoscopy, urodynamics, those are if you can't figure out what's going on or there's something abnormal with some of the 5 things above, then you follow those things with the cystoscopy or urodynamics. Or if there's other things going on in the next category over here where it says additional evaluation should be performed in the event that the patient has pretty significant lower urinary tract symptoms as well, or they have significant prolapse that you see, or they're really not emptying their bladder, they have a PVR of 300. Something else is going on that's also contributing to that stress incontinence, and further evaluation is needed. When we look at the treatment algorithm here, we start off with the non-surgical options here on the top. Continence pessary, vaginal inserts, or pelvic floor muscle exercises with or without biofeedback. If those things aren't working, then we move on to the surgical realm. And in the surgical realm, again, there are 4 main categories of options. And those are what we're going to talk about here with our panel today, as well as the non-surgical options. The bulking agents, mid-urethral sling, autologous fascial pubovaginal sling, and birch copal suspension. To my surprise, I will admit, I always give my input here, is still on the list, in spite of the fact that the data isn't always as strong compared to the other options that we have. But there are reasons why someone might want to do a birch. So the little arrow that comes off of the mid-urethral sling, this was the guidelines in 2017, and there was a little qualifier here. It said if you're going to do a mid-urethral sling, you offer the patient, the index patient, right, straightforward stress incontinence, a mid-urethral sling, you offer her a retropubic or a transobturator sling, because there's good data in our literature to support both of those, that they're equal efficacy with low risk. If you're going to offer a single incision sling, that's what this little box says, you have to be honest about the immaturity of the data available in our literature, saying we think the procedure works well, but we don't know how long it lasts. And that just speaks to the fact that, you know, it's the thing that came to the party last, right? It was FDA approved in 2008, started to be used a little bit more widely 2010s, and so we didn't have a lot of long-term data in 2017. Today, oops, there's our box. Today, however, there was an amendment that was made by the AUA SUFU panel in just last year, in 2023, and looked at the data available today, and now we do see some good long-term data on the single incision slings, and so they changed that little red box. If a mid-urethral sling is selected, clinicians may offer retropubic, transobturator, or single incision sling to the index patient. So it's an important amendment that was done just last year. So when we look at the bottom part of this graph, it says the special cases. Those are the things we're going to talk about a little bit here today too. Those are the situations where you really need to think about what kind of procedure do I want to do? Do I need to deviate from my sort of algorithm, my knee-jerk reaction kind of things? And those are some of the things that we're going to talk about.